Hi everyone, this is Michael Reinhardt, Dr. Michael Reinhardt from the State University of New York, Downstate Health Sciences University. And I'm here today as part of the Brooklyn Initiative to Develop Geriatrics Education, which is one of the geriatric workforce enhancement programs funded by the Health Resources and Services Administration of the Department of Health. It's my pleasure to be here today to talk with you about interprofessional teams and the interprofessional care of older adults, and what are the evidence-based models for this care. This lecture is part of a larger group of lectures that you will hopefully be taking part in. This is the third lecture in our series, and this is what that lecture series looks like. We'd like to acknowledge the funding we have from the Health Resources and Services Administration, both the Geriatric Workforce Enhancement Program and a recent CARES Act supplement grant to that program, as well as my own Geriatric Academic Career Award. I have no conflicts of interest. And these are some of the commonly used acronyms you might hear us say during the course of our talks. Most commonly, we refer to our program as BRIDGE for short, and GWEP for the overall funding program that funds us to be here today giving you these really important talks. And as a reminder, all of our talks are framed around age-friendly healthcare and the 4 M's: what matters to the patient, medication, mentation, and mobility. These 4 cornerstones of geriatric care are vital to the health of our older adults and to providing quality care to older adults throughout the region and the country. SUNY Downstate and the BRIDGE program are participants in the IHI's Age-Friendly Health Systems Initiative, and we're proud to be improving the quality of care for Brooklyn's elders. So before we get started, though, I'd like you to engage your brain. Put on your thinking hat and think about your own experiences working in healthcare and your own experiences in teams. What's the worst experience you've ever had? The best experience you've ever had working in a healthcare team or any team? And how does your current team environment compare? I'd like for you to pause your video for a second to take a minute to write down your answers. There should be a place online for you to insert your answers, and so that we can discuss as a team when you come into the clinic. And now I'd like for you to consider for a moment a common, multi-complex patient, a patient with multiple medical comorbidities. Not an out-of-the-ordinary patient, but one you have definitely seen in your clinical practice and will see again. Mrs. Colon presents to your clinic for her semi-annual checkup. She's a kindly 87-year-old Hispanic woman of Puerto Rican descent, English and Spanish speaking, retired, widowed, and living by herself in a 4th-floor walk-up apartment in Brooklyn, New York. And this represents many of the patients we see aging in place here in New York City, aging into environments that were quite healthy when they were younger, but maybe a little more difficult as they age. Her past medical history includes hypertension, hyperlipidemia, congestive heart failure, type 2 diabetes, osteoarthritis, osteopenia, falls, 2 falls in the last year, mild cognitive impairment, no past psychiatric history, and she's had both of her cataracts removed with lens replacement. She's had total knee replacement on the right side. She has a family history of diabetes and myocardial infarction. So far, we definitely meet the criteria for multi-comorbidity, and these are her current medications: metformin, insulin glargine and aspart, carvedilol, furosemide, atorvastatin, alendronate, acetaminophen, ginkgo biloba, and aspirin. And you should start to be thinking already, as we're looking at this, how she fits into the 4 M's model. How are we doing medication-wise? Is she experiencing polypharmacy? Are any of these meds high risk for older adults? Is there anything that might be eliminated or improved or optimized? And yes, she is experiencing polypharmacy by the most standard definition of being on 5 or more medications, which places her at all sorts of risks, including increased risk of adverse effects and, of course, increased risk of falls. And we already know poor Mrs. Colon has already had 2 falls in the past year. Mrs. Colon was born in Puerto Rico and she has 5 siblings, unfortunately 4 of whom are deceased. She was married for 60 years but unfortunately also has been widowed for these past 4 years. She has 3 children, all living in New York City, which is great, right? Potential source of support. She was a retired nurse, Catholic, attends church weekly, but doesn't attend a senior center, so she's modestly connected to the community at large and hopefully to her family as well. And I would add a bit about her personality. She's a fiercely independent woman, highly intelligent retired nurse who really wants to have full control of her care and to remain in her home environment as long as possible. Substance history-wise, no cigarette use, thankfully, but she does drink 2 to 3 glasses of wine per day, no drug use. And at this point, we don't know what 2 to 3 glasses of wine means for Mrs. Cologne. Does that conform to my definition of 2 to 3 glasses of wine, or is it her own definition? But we're starting to get a little worried at this point, considering her history of falls, and also in combination with her polypharmacy and alcohol consumption. So let's pause for a second and have another brainstorm. What are your thoughts so far about the complexity of this patient, Mrs. Cologne? How would you manage her care in your current clinical environment? Could you manage her care? Are you operating by yourself, or do you operate in a team? Would you need to make referrals? And what referrals would you need to make? What would be the ideal model of care for Mrs. Cologne? Pause the video for a minute and write down your answers so that we can discuss them when you come into clinic. Ideally, the geriatric patient would be obtaining care from all providers simultaneously. Really, we are in an all-hands-on-deck scenario for the common multi-complex older adult. They need geriatricians and nursing, caregivers and family, psychologists, CNAs, dentists and dental hygienists, PAs, social workers, dietitians, occupational and physical therapists. The whole smorgasbord of healthcare professionals should ideally be involved in the care of patients like Mrs. Cologne. And as we'll see, outcomes actually improve when we do this in the right way. Complex needs require a team-based approach. Geriatric patients are complicated. Multiple comorbidities with multiple contributing factors. Multiple treatments are needed, and multiple professionals are required. And of course, care quality is improved when a multiplicity of professionals are working together to handle the multi-complexity of the patient as an interprofessional team. And team is the operative word. We really need everyone all together. And so let's take a minute to define interprofessional team-based care and how it differentiates from some of the other common words you might be hearing in the healthcare environment. So first, multidisciplinary teamwork. So multidisciplinary teamwork is similar to interprofessional teamwork, but it involves different disciplines rather than professions. For instance, on our bridge team, in addition to being interprofessional, we're also multidisciplinary. In addition to healthcare professionals, we also have a really gifted medical anthropologist on our team who's in a completely different discipline but augments and amplifies our care and education dramatically. And information is shared across disciplines, but they don't sit together in multidisciplinary teamwork and formulate a team plan together, all right? A team treatment plan. And this is differentiated from interdisciplinary teamwork, in which people collaborate across different disciplines rather than healthcare professions. And information is shared across disciplines, and the disciplines do work together to form treatment plans, similar to our own model. And in interprofessional teams, we're talking mainly about interprofessional teams of healthcare professionals that are working together as a team with clear roles and shared treatment planning. So everyone is on board working together to get to the goals that the patient has for their own care and that we have as healthcare providers. And of course, I want to take a minute to talk about interprofessional education versus interprofessional practice, because as we know, the environments that we train in as trainees, as students, we are more likely to adopt as we move into practice. So it's really important that we not only, as practicing providers, learn to practice in interprofessional teams, but that this training start much earlier on as people are moving through their different professional schools and into practice. So interprofessional education, much like interprofessional practice, is an activity that occurs when members or students of trainees of 2 or more healthcare professions engage in learning and clinical training together. And interprofessional practice, in comparison, centers on the actual provision of patient care in an interprofessional team. Interprofessional education is becoming more and more formalized and has gotten national and international attention. There are, of course, core competencies for this educational programming, of which we also adhere as part of the Bridge program. You'll notice in the handouts regarding these sessions, our self-learning modules, that all of the interprofessional education collaborative core competencies for each module are included. And these cross the values and ethics for interprofessional practice, roles and responsibilities for collaborative practice, interprofessional communication, and of course, interprofessional teamwork and team-based care. Interprofessional education and training started back really in the United States intensively with a round of federal funding that encompassed both the VA with a program in the 1970s for interdisciplinary team training in geriatrics, and crossing into the 80s and 90s with 2 HRSA programs, the Geriatric Education Centers and the Geriatric Academic Career Awards. The Geriatric Education Centers are the precursor to our current funding that brings us here today, and the Geriatric Academic Career Awards are K awards designed to train interprofessional healthcare professionals to become leaders in geriatrics education and care. And this is the award that I currently am working on here at Downstate. And this, of course, there's been other iterations, including the Hartford Geriatric Interdisciplinary Team Training, which advanced through the early 2000s into the 2013 Geriatric Workforce Enhancement Program, which was designed by HRSA, and which we are now funded as part of the Bridge program. But let's now take some time and turn to the models of care that currently exist. What are the evidence-based models of care that you as a student, trainee, or provider might use to improve the quality of care in your practice environment and improve the outcomes for older adults here in Brooklyn? And of course, there are disease-specific, program-specific, and site-specific models of care. And we're going to take a few minutes to step through these in a site-specific sort of way. And so these are some of the models that are available across different segments of the healthcare continuum, from acute care through care transitions to community-based care and home-based services. First, we're going to take a look at inpatient models of interprofessional care for older adults. And this is one of my favorite models of care for inpatient older adults. And the reason it's my favorite is because it really breaks down some ageist barriers that exist within the healthcare system. And if you take a look at this model, what you'll notice at the very top of this first figure is that in this model, they expect that we take in a functional older person and we discharge a functional older person. And this goes against much of the dogma that you might find in many inpatient units, in which there is some expectation that deficits will accrue within their inpatient hospitalization, and that we have to develop disposition and treatment plans that will handle those deficits. In the ACE unit model, the acute care for the elderly model, we take an older adult who has an acute illness and is going to be hospitalized, and we anticipate the potential deficits that could occur if we don't act early enough, and we prehab those individuals for patient-centered care. We take a look and we create a prepared environment, interdisciplinary collaborative care, interprofessional care, multidimensional assessment and non-pharm prescriptions, med review, home planning, transitional care, and create an entire system of care that then allows older adults to leave the inpatient setting with improved mood, positive expectations, reduced impairment, and decreased iatrogenic risk as compared to care as normal. And of course, as in the ideal scenario, the functional older adult will then be discharged back to their home environment to go on about their everyday life. In your current care system, I want you to stop and think about how that compares to the model of ACE care. And think about ways in which implicit biases might be playing into your dispositions for patients, and how we might improve those outcomes and those models of care and stop ageism within the healthcare setting. And so this is just an outline of ACE care versus care as usual. And there's improved physical outcomes, less disability, less falls, better mobility, improved quality of care, reduced 30-day admissions, shorter length of stay, improved cost, and of course, improved satisfaction. Caregivers, nurses, physicians, patients all have a sense of improved satisfaction in this model of care because outcomes have improved, right? And they're working together with a whole team. And this is comparable to the MACE model, which is a mobile acute care for elders model, which takes the ACE model and basically recognizes that some hospital settings may not be able to dedicate a particular space to have an ACE unit for older adults. So instead they make it mobile and adaptive. And they take the same ACE team and they make them mobile and able to move around the hospital in a consultative fashion and provide the same level of ACE care on regular med-surg units. Same interprofessional team, excellent outcomes. Decreased reportable events, decreased length of stay, and of course, improved satisfaction with care again. And there are programs like the Hospital Elderly Life Program, which is focused on reducing or preventing delirium in elders, targeting older adults 70 years and older with one or more delirium risk factors, and targeting them with 6 protocols that reduce or prevent delirium across 6 different domains. And this is what that model of care looks like. With protocols that are targeting visual impairment, hearing impairment, dehydration, immobility, sleep deprivation, and cognition. This model is really important in the inpatient setting, has been shown to reduce delirium incidence by up to 40%, decreased duration and number of episodes. Unfortunately, there's no difference in severity or recurrence once delirium has set in, but we seem to be able to prevent quite a bit. It's been broadly implemented, and it often is cross-implemented with other programs like ACE and NEACH that I'm going to talk about in a minute. Training and replication resources are freely available online, and I would encourage anyone watching this to take a look. This can be very easily implemented in any hospital setting. And of course, there's a niche model, Nurses Improving Care for Health System Elders, which takes, it's just a nursing care model looking at improving quality of care and nursing knowledge, skills, and attitudes in geriatric care. So this model is focused on improving nursing skills and knowledge when caring for older adults by providing the training and tools necessary for those professionals to be feeling competent in providing geriatric care. They model interprofessional team care, and they provide education on very specific topics which are important for care quality in older adults, including pain management, pressure ulcers, adverse med events, delirium, falls, and urinary incontinence. And of course, this is happening in an interprofessional team setting, and the outcomes include improved quality of care, among others. As you're listening to me speak, let's take a minute and have another brainstorm. How are the 4 M's incorporated into these models? I didn't call them out directly as we went through because I wanted you to go back and think about each of those models of care and how each of those M's is incorporated into each one, and it might improve the quality of care for older adults. Medication, mentation, mobility, and what matters. How might you build a new model that utilizes the 4 M's as at their core? Something that is particular to your environment, perhaps. How might you adapt one of these models to fit your current care environment with the goal of improving the care for older adults? So let's pause the video here for a couple minutes and think about that. Next, let's take a look at transition of care models for the interprofessional care of older adults. So these are models of care for older adults that are moving from the inpatient setting back to the ambulatory care setting. And there's quite a few of these. There's the TCM model, transitional care model, that is designed to improve discharge and transition of care from acute hospital stays by ensuring follow-up care, providing early discharge planning with the interprofessional team, and providing follow-up at home for 2 months after discharge, comprehensive assessments of person-centered goals and the person's needs and their home safety. And of course, operating in an interprofessional team, including the team leader being a trained transitional care nurse who coordinates care across the interprofessional team. And outcomes, again, are better. Reduced 30 and 90-day readmissions, reduced cost of care, at 90 days and improved cost effectiveness. There's the CTP model, Care Transitions Program. So in this model, which is again designed to reduce readmissions, there's 4 main components that I'll talk about on the next slide. The team meets at discharge and educates the patient on these main topics. And then they provide 2 or more home visits within 30 days of discharge. The interprofessional team is made up of a care transitions coach, usually a nurse practitioner, who coordinates with the interprofessional treatment team at large. And again, outcomes are improved, reduced readmissions, reduced cost of care. And this is what that model looks like. They provide education on medication self-management, improving the patient's self-efficacy for taking their own medications, understanding what potential side effects are, and how they might impact their lives, and what to look for when things aren't going right. Providing patient-centered record keeping, connecting the person to their own medical records so that they have some ownership of what's happening in their care. Again, providing follow-up, and of course, warning and educating the patient about what the red flags are so that they understand what to look for when things are going wrong in their care, and when to escalate to their providers to get more help. There are other care transition models as well, like Project Red and Boost, that I'm not going to talk about today. Now I'm going to take a few minutes and turn to outpatient models of interprofessional care, starting with the Geriatric Evaluation and Management Model, or GEM. And so this takes some common knowledge in geriatric circles, which is that comprehensive geriatric assessments, which are the gold standard of geriatric evaluations for new patients, are more beneficial to the patient period, and they are again more beneficial when performed by an interprofessional team that is equipped to handle the complexity of that patient. So the GEM team co-manages patients with a primary care doc, either for tune-ups or for long-term care. So it's not that the GEM team is fully owning the patient, they're working with primary care in tandem to give tune-ups as needed. And sometimes when needed, they do take over, but for the most part, it's about co-managing and giving quality tune-ups here and there as appropriate. And so again, composed of an interprofessional team, usually geriatricians, social workers, and clinical nurse specialists, ideally a geriatric NP. And here again, outcomes are improved. Patients less likely to have functional decline or limitations, less depression, less home care services. And primary care, of course, has high satisfaction with this model because they're having some high-quality consultation and their patient outcomes are better. Unfortunately, it is cost neutral, but that's, I suppose, better than cost negative. And then there's the PACE model, the Program for All-Inclusive Care for the Elderly. This is a great program that's designed to provide comprehensive primary care for people 55 and older who would otherwise be candidates for nursing home placement, very complex patients. So PACE programs receive a capitated payment from Medicare and Medicaid. What that means is they receive a payment per head to provide comprehensive care per patient in their PACE program. And so they can do whatever they need to do with those funds to provide comprehensive, high-quality care and avoid nursing home placement. They have complete discretion over their care within the rubric of the PACE program. So they're incentivized to provide high-quality care that limits unnecessary treatment and hospitalizations. And if they do that in a high-quality way, which they often do, they have extra money to fund other programming that meets the needs of their patient population. Does their patient population live in a food desert? If they've managed to provide high-quality care that limited unnecessary hospital stays, then that PACE program would be able to perhaps provide a nutrition program for those patients, etc. And so this flexible structure, which exists outside of the standard structure of Medicare and Medicaid reimbursement, is really ideal for this complex patient group. And of course, it's a one-stop shop. It's occurring at a day health center with everything in that location. And so the whole interprofessional team is there and they coordinate together and outcomes are great. Enrollees stay in the community longer. They age in place, which is my goal for every patient in our clinic. And they have improved rates of hospitalization, readmission, cost of care, and survival. Then there's the GRACE model, the Geriatric Resources for Assessment and Care of Elders. And so this is another interprofessional team care model that targets low-income elders across 12 domains of care with the overall goal of optimizing the health and functional status of older adults, decreasing excess healthcare use, and preventing long-term nursing home placement. The interprofessional team is, again, this broad interprofessional team which older adults need, and the outcomes are great. And this is what that model looks like. The team is divided into a support team, which is a nurse practitioner and social worker, and a main team. The support team is responsible for going out to the patient or evaluating the patient in clinic, conducting the comprehensive geriatric assessment, and then bringing that information back to the interprofessional team, who develops a care plan utilizing overall GRACE protocols for each of the 12 domains of care. The support team then coordinates that care with the primary care doc and implements the plan and tracks outcomes using software and electronic health records. Thinking about these models, right? What are the key ingredients of these models that make them effective in improving patient outcomes? And who's driving the bus in these models? What are the team roles? And how does having a leader and a specific team roles impact care? Pause the video for a couple minutes and think about that and write down your answers. So we're going to talk briefly about a couple of other models, including hospital at home, which is a really interesting model that's trying to divert people 65 and older who are in need of inpatient admission from inpatient admission to receive their care at home, targeting some diagnoses that are really common reasons for ER visits and hospitalizations in older adults, including community-acquired pneumonia, heart failure, COPD, and cellulitis. And so if the patients are eligible, they're diverted to care at home, and they get nursing and physician care at home. That's their interprofessional team, a focused interprofessional team. They get all of their care, their equipment, their meds at home. All the testing is conducted at home. And when they're ready, they're discharged back to their primary care doc. And the outcomes are what you'd expect. Again, positive. Decreased length of stay, high patient and caregiver satisfaction. No one wants to be in the hospital. They love being at home to get treatment. And decreased delirium. They're in their home environment in a setting they know. It's not confusing. And decreased cost of care. And a similar model, but home-based primary care, so bringing primary care to the home, very commonly used by the VA. Designed for frail older adults with multiple comorbidities. And so primary care is given directly in the patient's home. It involves care coordination, home visits, telephone calls, with a broad interprofessional team that's usually funded by the VA. Geriatricians, NPs, social workers, LPNs, and office coordinators. And the outcomes, again, include high patient satisfaction. And there's the interprofessional model for practice, model of practice for aging and complex treatments, the IMPACT model. So here the interprofessional team is, again, a broad team including primary care, nursing, pharmacy, PT/OT, dietitians, and social workers. And it also incorporates, importantly, trainees from each profession. So this is more similar to our model of care in the Center of Excellence for Alzheimer's Disease at SUNY Downstate, in which we incorporate a broad panel of healthcare professionals and also trainees from each profession into patient care. And the outcomes here are great. And so this is what that model looks like. Interprofessional care and education are wrapped around all of the professionals working together to provide care to the patient and family across a very intensive impact clinic protocol that involves patient selection, comprehensive assessment, team meetings, team planning, person-centered care planning, and iterative care review and implementation to improve and optimize care outcomes. So let's turn back to our patient and talk about her interval history. So earlier we reviewed her past history, and now she's in your office and we're getting an update by problem. In regard to her falls, since last appointment, the patient has had 2 new ER visits for falls. This makes her very high risk for falls if she wasn't already. Both happened at night, no head injuries, but now she has a right wrist fracture. In regard to her hypertension, the patient was not able to keep a log of BP, but she does now have current hypertension, 157/94. So we're looking at her and we're thinking, where are the holes in her care? Where can we intervene as an interprofessional team to improve her outcome and prevent falls and optimize either her medication adherence or medication plan? Thinking again about the 4 M's, right? Here we're seeing some problems in mobility. and perhaps medications as well. In regard to her heart failure, she's now sleeping on 2 pillows. She's only able to walk 1 block without resting or 1 flight of stairs. And there should be an alarm bell going off in your head right now as you think about her living environment. Mrs. Cologne lives on the 4th floor of a 4-story walk-up building in Brooklyn. And so it must be taking her a whole lot of time to move up and down those stairs, one. And also, if she is getting dizzy and out of breath at each flight, is she at further fall risk on the stairs and at risk for severe injury? Mobility, right? One of the 4 M's. Her diabetes. Patient was not able to keep a log. Finger stick, 189 today. Hemoglobin A1C, 8.9. She's not controlled and has not modified her diet. But thinking again about what's going on with her, put on your thinking hat. She has a broken right wrist. Is she able to cook? Probably not. Is she ordering in? Probably. And it's hard to get inexpensive, healthy delivery food, even in New York City. Hyperlipidemia, again, she hasn't modified her diet. Osteoporosis. She's taking Tylenol multiple times a day, and 4 M's. We're thinking about medication here and how that Tylenol is impacting her liver and how it's impacting, perhaps interacting with other meds, and how it's also interacting with her alcohol consumption. We don't know where she is right now with that alcohol use. Mentation-wise, her mini mental is 26 out of 30 today. That's still within the normal range, but perhaps off her baseline. She doesn't have any functional deficits from her cognitive impairment, so she doesn't qualify as having a diagnosis of dementia. And then on to her alcohol. So she's still drinking 3 large glasses of wine, and so now we're wise to what's happening, and we're asking a few more questions. What does 2 to 3 glasses mean? And it wasn't the standard 4 to 5 ounce glass of wine. It was a full 12 ounce glass, perhaps 8 to 12 ounce glass that she was drinking 3 of per day. And so actually the actual number of drinks that she was getting was somewhere in the neighborhood of 6 to 10. But she didn't see this as a problem, saying, I'm retired, I'm independent, I'll do what I want with my time. Very resistant to any insinuation that this was too much for her. Social history-wise, interval history, she stopped attending church. She had due to the difficulty with the stairs. Her children aren't visiting due to their work schedules. They call her, but they're not visiting. And she doesn't have a home health aide. So now we have a woman, fiercely independent, who's had 2 new falls, right wrist fracture, having difficulty cooking for herself, difficulty ambulating up and down stairs, and relatively isolated from all of her social network. We need everyone on board, right? The whole interprofessional team. Geriatricians, nursing, PT, OT, social work, pharmacy. And she's been losing weight. Preventive care-wise, she hasn't engaged in any of the preventive care that you'd referred her for based on her comorbidities. No optho, no podiatry, no dentistry. So we need these guys involved in her care too. And on asking what matters most to our patient, she said, I want to stay in my home. This is where my whole family was raised, and my husband passed. And so now we have to be thinking as an interprofessional team about this patient and how we can take in all of her complexity and help her to meet her goal of aging in her home. This is a tricky one, but it's important. And just a reminder about her medications in case you'd forgotten. So I'd like to have a stop for a second to remind you to confront ageism when it happens. It's very common with a case like this for us to push for the patient to perhaps have placement into an assisted living or other skilled nursing facility perhaps. But we have to take into account the patient's goal for herself, what is most important to her and what's going to help her maintain her happiness, her mentation, which includes her mood and affect, and her long-term life goals. And that, at this point, does not include placement into a facility, certainly. And so we have to check ourselves and make sure that our care is in line with our patient's desires and find the best middle ground in which everyone is satisfied with both patient safety, patient care, and person-centered outcome. So as we've been doing all along, I'd like you to pause for a minute and consider this patient in the context of the 4 M's. Take a moment to write down how you think we're doing with her care across each of those 4 M's: medication, mentation, mobility, and what matters. What should we do as a team to optimize her care and ensure that we adhere to what matters? And again, think again about what model of care might serve this patient best. Think about those models that we went through. Now let's turn a second to the implementation of interprofessional teams. I hope that I've convinced you, I really hope that I've convinced you, this is how we should be practicing care in geriatrics. We should not be practicing in isolation. We should be practicing together with a broad panel of interprofessional healthcare professionals to really improve outcomes, as we've seen can happen when these models are implemented correctly. And I hope that you're thinking, how can I do this in my environment? How can I change my system of care so that it better fits the actual needs of older adults? So when you're thinking about this, you have to know the available models. That's why we just talked through. And you have to really put your business hat on and think about a business plan and a clinic protocol. What is this going to look like in your environment, and how is it going to fit in with your overall healthcare system's model of care, payer environment, available staffing, and how can things be reworked to fit one of these models of care or a new model of care of your designing? And then you have to be ready to train your team and, of course, track outcomes, constantly quality improve so that you can fine-tune your model, fine-tune your team, and improve patient outcomes as you wanted to. You have to think about the elements of interprofessional team practice when you're designing these teams. Make sure there are clear roles so that individual team members know their responsibilities and can act on them. You have to ensure that there are clear team procedures so that there's accountability. You have to coordinate, and you have to make sure there are adequate venues for communication in terms of team meetings or digital communication via things like Microsoft Teams or whatever, or Epic, whatever model of communication you're using in your practice. And you have to be willing to cooperate. And just as important as cooperation is you have to empower your team members to be assertive when they have something to say that is important about an individual patient's care. All voices have to be heard on an interprofessional team or the model will fall apart. And you have to trust in your individual team members' ability to enact their entrustable professional activities and their roles on your team. There has to be mutual trust and respect, and a respect for each person's autonomy within the team structure. Each person has to feel valued. And so it turns out there are evidence-based models for training your interprofessional team as you're getting started with this. The Hartford's GIT program is available for purchase, but unfortunately it's no longer being updated. One of the more common models that's used here in New York City is Team Steps, which was developed by the Department of Defense. Evidence-based interprofessional team training has a curriculum guide, slide sets, videos, and live training as well, and is kept current and active by both, I think, by the AHRQ. So let's stop again and think about this thought exercise that I've just engaged you in. Pause the video after I finish talking and think about what are the barriers to implementation of interprofessional care in your workplace, and how can these barriers be overcome? Take a second and write down your answers, and we could talk about them when you come into clinic. So these are some of the common barriers to the implementation of interprofessional care that are discussed in the literature, not the least of which is the limited training of the current healthcare workforce, meaning people are not ready or prepared for interprofessional team-based care because many of them have not been trained in IP care when they were going through as students and trainees. And that's what we're here to change. That's what we're doing right now. Attitudinal, educational, siloed education, right? This is also something we're trying to break down here at Downstate with the Bridge program, bringing all the colleges and schools together to train together. System-based barriers. Systems exist and have existed sometimes for many years in their current structure, and there's a certain inertia that happens within a system, and it takes time to change those things. And of course, cost. There will be some startup cost, but as we've seen, the outcomes often dictate that cost improves over the long term once you've implemented these models of care. And of course, human resources. Geriatricians are, somewhat surprisingly, scarce resources. And so bringing in together a trained team of geriatricians across the different professions can be somewhat challenging. But the outcomes are really, really important and positive. And so this is what you have to include if you're developing a business plan or a model of care in your environment, your care environment. Professional satisfaction is improved. Doctors, nurses, social workers, dietitians, PT, OT, PA, so everybody feels happier when they operate in this environment because they think they're doing better for patients. Patient satisfaction is improved. Quality of care, pain, fall incidence goes down. Quality of life goes up. Independence of patients, depression and behavior are decreased. Transitions of care and length of stay, hospital length of stay and readmissions are all improved. Cost of care is decreased in many cases. So back to our patient to wrap up her case. So while planning her care, she suffered another fall in the home, fracturing her left wrist. So now we have a right fracture and a left fracture. And she was admitted to the hospital. She received alcohol detox in the hospital and was referred for outpatient substance treatment. APS, Adult Protective Services, got involved after the team notified APS that they were concerned regarding neglect by her children and home safety, and was eventually enrolled in a pilot nursing home diversion program, providing her with 24-hour home health care services. So the team did what they had to do. This is a case that had to be perhaps promoted to Adult Protective Services attention so that we could get everyone on board and make sure that a safe plan was put in place. We had to have the government basically involved in our interprofessional team. And then we took a look at all of those 4 M's: mobility, medication, mentation, and of course what matters. And we found a way through the system that allowed the patient to have her most important goal, to stay at home where she raised her kids and lived with her husband for 60 years. Really, really important. And as of this presentation, she's still living at home with her home health aides. Thank you for coming today, and I hope I've stimulated your thinking about interprofessional teams and the interprofessional care of older adults. We look forward to seeing you in clinic and discussing your answers to the questions from the brainstorms today.